Hello everyone, my name is Rajni Guru, lecturer from working in Assam Downtown University from the department Faculty of Nursing. So today I'm going to take a class on the topic pleural effusion. So let's see what is pleural effusion. So definition of pleural effusion says that it is an excess amount of fluid in the pleural cavity which will result from an imbalance in the normal rate of pleural fluid production or absorption, or it can be both. So what we understand from this definition is that we have our pleural cavity right in the lungs. So what happened there is in the pleural cavity there is a pleural space which contains fluid. So what happens in case of any kind of disease and all, there will be a problem in the there will be increase in the production, or sometimes there will be less absorption of this fluid. So or sometimes it can be both. So the patient will have excess amount of fluid in the pleural space. In the second definition, it says that pleural effusion is a condition refers to a condition of fluid in the pleural space. Next, coming to the incidence of pleural effusion. So under incidence of pleural effusion, you can see that according to WHO report, the estimated prevalence of pleural effusion is 320 cases per 1 lakh people in industrialized countries. And next, males are mostly affected commonly than females. That is the ratio is given 3:2, and India like 84 per 1 lakh every year is affected by pleural effusion. Next, coming to the types of pleural effusion. So there are basically two types of pleural effusion. One is your transitive pleural effusion and one is your exudative pleural effusion. So what happened in the transitive pleural effusion? Here what happened is a non-inflammatory type of pleural fluid collection, and then the color is like pale yellowish straw color, and this is due to the increase in the hydrostatic pressure, like in case of congestive heart failure and all. Then like you can see in case of cirrhosis, nephrotic syndrome, B and hypoalbuminemia. Next, coming to the next type, that is exudative pleural effusion. From the term exudative, is that we know that there is a presence of exudates. Exudates means what? Like a pus formation. Why? Because of the inflammatory case. So this type is an inflammatory type of pleural effusion. Like most commonly we'll see pneumonia, which is an infection of the lungs. Then in case of cancer, tuberculosis, viral infection, TB, and other autoimmune diseases. So these are the two types of pleural effusion. One is your non-inflammatory type, that's the transitive, there is no presence of bacteria, and one is your exudative type, which consists of bacterial invasion. Now coming to the types of fluid. So there are four types of fluid. One of course is the serous fluid, or also called as hydrothorax. This will result from the serous fluid accumulation in the pleural cavity. Then next is your blood, which is also called hemothorax, and in this condition there will be presence of blood in the pleural cavity. The next is presence of pus, we call it pyrothorax or empyema. And next is your chylothorax is a type of pleural effusion which will result from lymphatic fluid which will accumulate in the pleural cavity. Next, coming to the etiology of pleural effusion. So first etiology we'll say is effusion due to heart failure. So what happens mostly in case of left ventricular failure, there will be increase in the hydrostatic pressure, so there will be increased accumulation of fluid in the lungs. Then second etiology we'll say is hepatic hydrothorax. So what happens is, like for example, like cirrhosis, ascites. In those cases, what happens? The fluid will pass through the little holes in your diaphragm, and which will reach to your lungs again. The next is your parapneumonic effusion, like your lung infection and all, mostly lead to exudative type of effusion. Then effusion secondary to malignancy. Here also the person will have exudative type of pleural effusion. Why exudative? Because the patient will have like breast cancer, lung tumors and all. Then mesothelioma, presence of the mesothelial cells in the pleural space. Then next effusion secondary to pulmonary embolization. The next etiology related to tuberculosis due to tuberculosis pleuritis. Then effusion secondary to viral infection. Again, the patient will have acute type of infection. The next is your chylothorax. Chylothorax, as I have already said, that there will be presence of lymph fluid in the pleural space. Then next is your hemothorax, and lastly the miscellaneous other cause of pleural effusion. So these are the few types of etiology for pleural effusion. Next, coming to the pathophysiology. So under pathophysiology, you can see I have categorized under two types. I have given for both the types of pathophysiology. What happens? The patient is getting transudative pleural effusion. So if he have transudative, there will be alteration in the driving pressure, such as there will be increased hydrostatic pressure and decreased oncotic pressure. So what happened in case of the heart failure? Again, I'll take an example. So what happened? There will be increased amount of fluid, which will lead to the increased amount of fluid. And what happened? This fluid will be unable to remain in the intravascular space, and this will further lead to shifting of fluid from intravascular to interstitial space, and lastly leading to effusion. And the second type of pleural effusion, that is your exudative. Since exudative we know is all related to infection, so what happened? There will be invasion of these microorganisms, and this invasion of microorganisms will lead to initiation of the inflammatory reaction. As we all know, once we have infection in our body, our inflammatory mediators will start to react, and when they start to react, there will be vasodilation. There will be dilation of the blood vessels for the mediators to, as the mediators have started to accumulate, and there will be increased capillary permeability, and then which will lead to lack of plasma protein. And once there is a leakage of plasma protein from your blood, what happens? There will be decreased oncotic pressure, again further lead to shifting of fluid into the interstitial space. As we all know, protein is very important, as they act as a binding factor. Once our body feels protein from our body, we can see the fluid will start shifting from the intra to interstitial space. So these are the two pathophysiology. Next, coming to the clinical manifestation. So clinical manifestation, the sign and symptoms depends on the size. Like if they have a large effusion, the patient will have a pleurisy, that is pain in the pleural space. Then the patient will again have shortness of breath. And it is always worse when the patient is in a lying down position. And if the pleural effusion is very small, like less amount, then it may go unnoticed. So other characteristics are like, as is written there, dyspnea, symptom of hypoxia. They'll have pleuritic chest pain, dry non-productive cough, and underlying disease like fever, empyema, cachexia, and in case of malignancy and symptoms of left-sided heart failure. So these are the clinical manifestation of pleural effusion. Next, coming to the history and physical examination. So first of all, we have to take history, as we have to remember all the etiologies. Keeping in mind the etiologies, we have to take history from the patient and the family member. If they have any cardiac related problem like congestive heart failure, or if they have any renal or liver impairment, like if the patient is, whether the patient is even like in case of liver cirrhosis, and also it can lead to pleural effusion. So all this relating to recalling the etiology, we have to take the history, and also we have to take history of smoking towards malignant pleural effusion. And next, physical examination. So in the physical examination, you can see movement will be diminished fullness of intercostal space, and you will see the trail sign will be positive on opposite sign. As in the diagram it has said, in the trail sign will be present where there will be a shifting of your like forward tilted of your trachea, bending of your trachea. Then trachea apex speed may be shifted depending on the amount of the fluid which is present. Then there will be decreased chest wall movement, as obviously the pleural space is filled with fluid, and we need a space whenever we take an inhalation and exhalation. Our chest cavity is moving, right? So, but when we have a pleural effusion. What happened? There will be a decrease in this chest wall movement. Then next, the region overlying fluid will be dull. Then delay shifting dullness may be present absent in mexical inoculated effusion. And lastly, there will be decreased with sound on auscultation. Another investigation you can do is your chest X-ray to confirm the diagnosis, ultrasonography, thorax, then next CT thorax, and also PET scan in case the patient is having any kind of malignancy, tumors, and all. Others are like your thoracentesis. Thoracentesis is done for both therapeutic and diagnostic purposes. And then next, percutaneous pleural biopsy and your thoracoscopy, where the large pleural tissue under the way it helps to take large pleural tissue under direct vision. Coming to the management of pleural effusion, also we have importantly 3 objectives while treating this kind of cases. So first we have to discover what is the main cause of this pleural effusion, whether we have to know whether it's a transient type or exudative type, and we have next our goal is to prevent reaccumulation of pleural fluid, and lastly to relieve discomfort, dyspnea, and any type of respiratory compromise. So next, under medical treatment, we can see medicine like we can give nitrous and diuretics, because the patient will have, if the patient is prescribed for the congestive heart failure, and in case of pulmonary edema, as you can see there, and in the pathophysiology also we have discussed that there will be a shifting of fluid, right? So what happened, the shifting of fluid, there will be increased amount of fluid in the chest cavity. So that's why we are going to prescribe diuretics like your injection furosemide and all, as prescribed by the physician. Then next we can go for your anticoagulants in case if the patient have embolism, pulmonary embolism. Then next we can go for antibiotics in the by finding out what is the exact cause of exudative type of pleural effusion. Then next we can do a chest tube drainage, chemotherapy, radiotherapy, or surgical intervention for all the malignant type of pleural effusion. Next, coming to the surgical management for patients. So under surgical management, we can do is your thoracentesis. Thoracentesis, as previously also I have said, it can be a therapeutic purpose and can be diagnostic purpose. So now in here we can see it's a therapeutic purpose where we are going to aspirate the fluid. We are going to aspirate out the fluid, and then you can see in the diagram also how they are locating the area where the fluid is accumulated under the guidance, and this things we are going to do under the guidance of the sonography. And next, chemical fluoridosis. And here in the chemical fluoridosis, it is performed to obliterate the pleural space and prevent reaccumulation of the effusion fluid in both in case of malignant and also in case of non-malignant cases. And next, pleurectomy. It consists of here we are going to remove stripping of the parietal pleura from the visceral pleura. Then next, this produces an inflammatory reaction that causes additional formation between the two layers as they here. And next, surgical management you can see is thoracotomy. Here they are performing by removing all the fibrous tissue, and also they are going to evacuate the infection from the pleural space. And lastly, VATS, that is the video assisted thoracoscopic surgery. So these are all your surgical management for pleural effusion. Next, coming to the complications. So the complication can be like large effusion can lead to respiratory failure. Then they will have a pneumothorax, which is presence of air in the thoracic cavity. Then again hemothorax, presence of blood in the thoracic cavity. And lastly, empyema, presence of pus. Now coming to the nursing management, first we are going to discuss about the nursing diagnosis. So first priority nursing diagnosis will be our ineffective breathing pattern, which is related to decreased lung volume capacity as evidenced by tachypnea. And there are certain assessment we can do by like monitor, record vital sign. We can elevate the patient head. We can encourage the patient to do deep breathing exercises, and also we can ask the patient to use relaxation technique and administer any supplemental oxygen as ordered, like your nebulization and all. The next, diagnosis here: impaired gas exchange, which is related to alveolar capillary membrane changes and respiratory fatigue secondary to pleural effusion. And here we are going to monitor the respiratory rate, depth, and rhythm, and we are also going to auscultate the breath sound. We are going to encourage the frequent position change and also again deep breathing exercises, provide supplement oxygen at lowest concentration indicated, and prescribe medication as ordered. And other nursing diagnoses are your activity intolerance, and also we can formulate diagnosis on acute pain. As we see in the sign and symptom, the patient is developing like if the patient develops pleuritic chest pain or not. Coming to the health education, patient education and health maintenance for the patient, we are going to teach the patient deep breathing and coughing exercise to minimize the risk of lung infection. Next education is advise the patient to drink liquid air directed, as it will help keep air passes moist and better able to get rid of germs and other irritants. Then also we are going to instruct the patient to avoid smoking, and also not only smoking, we can ask the patient to avoid all the bad habits like drinking and also to prevent from any liver disease. Then take medications exactly as directed. Then instruct patient family to contact healthcare provider if they develop any of the following symptoms like fever, breathing problem, pain which will not go away, lips and fingernails will start to turn blue. We are going to immediately ask them to report. So these are the few patient education and health maintenance we can give to the pleural effusion patients. Thank you.